Hello everyone and welcome. Thanks to your support, our channel has continued to grow steadily and has now surpassed 600 subscribers. We truly appreciate it. We will keep working hard to provide valuable content for all those practicing clinical anesthesia or studying anesthesiology and pain medicine. Today we're diving into an absolutely massive topic: anesthesia for orthopedic surgery. And look, this isn't just about bones and joints, is it? It's about navigating some really unique physiological challenges, from frankly catastrophic embolic events to some of the most complex airway management you'll ever face. So we're going to systematically break it all down.
Okay, so here's how we're going to tackle this. We've set this up as a progressive deep dive. First up, we'll kick off with the foundational perioperative risks that you'll pretty much encounter in any major ortho case. That's bone cement and tourniquets. Then, we'll get into the really life-threatening risks of embolism and the absolutely critical importance of thromboprophylaxis. From there, we'll have a look at adapting our plans for special patient populations, because not everyone is straightforward, are they? And finally, we'll apply all of this knowledge to specific, high-volume procedures like hips, knees, shoulders, and of course, complex spine surgery.
Right, let's get started with part 1, the foundational risks. I like to think of bone cement implantation syndrome, tourniquet physiology, fat embolism, and DVT as the 4 horsemen of orthopedic anesthesia. They're the major threats we are always on guard for. We'll begin with the first 2, which are direct consequences of the surgical technique itself: cement and tourniquets.
So what exactly is bone cement implantation syndrome, or BCIS? Well, it's a truly dramatic and, frankly, terrifying intraoperative event. When the surgeon is forcing that polymethyl methacrylate, or PMMA cement, into the femoral canal, the pressure inside the bone, the intramedullary pressure, can just skyrocket to over 500 millimeters of mercury. This basically acts like a high-pressure shotgun, blasting a shower of fat, bone marrow, tiny cement particles, and air directly into the venous circulation. And of course, these emboli travel straight to the lungs, causing a massive VQ mismatch and ultimately cardiovascular collapse. The clinical picture is stark: sudden, profound hypoxia, devastating hypotension, arrhythmias that can range from heart block all the way to a systole, a huge spike in pulmonary vascular resistance, and a precipitous, terrifying drop in cardiac output.
This slide really lays out our battle plan, and it's a plan that requires us to be both proactive and reactive. The absolute highest risk period is during the insertion of that femoral prosthesis, so clear, closed-loop communication with the surgeon is just paramount. Proactively, just before they start cementing, we're going to crank up the FiO2 to 100% to build an oxygen reserve, and we'll make absolutely certain the patient is euvolemic to withstand any hemodynamic insults. From the surgical side, creating a vent hole in the distal femur can act as a sort of pressure release valve, while using high-pressure lavage helps clear out potential embolic junk. If BCIS still happens, the response has got to be immediate. 100% oxygen, get the fluids in aggressively, and have a very low threshold for starting vasopressors or inotropes to support that failing heart.
Now, the risk of BCIS is directly tied to which type of prosthesis is being used, and this slide shows the choice that surgeons have to make. For older, less active patients, maybe with a bit of osteoporosis, cemented prostheses are often preferred because they give immediate rock-solid fixation, but that comes with the built-in risk of BCIS. On the other hand, for younger, more active patients with good bone quality, a cementless prosthesis is often the way to go. This has a porous surface that allows the patient's own bone to grow right into it, creating this really durable biological fixation. This completely avoids the risk of BCIS, but, it does require a healthier patient and a longer recovery time.
And here is exactly what that looks like in real life. This is an X-ray of an uncemented total hip replacement. You can see how the stem of the prosthesis is just press-fit directly into the femoral canal. See that? Notice the complete absence of that white, hazy density that you would normally see with cement. The long-term success of this joint relies entirely on the patient's bone integrating with that textured metallic surface. It's a fantastic bit of bioengineering, and, most importantly for us, it means the immediate risk of BCIS in this particular case is basically zero. Okay, let's move on to our second common challenge: the pneumatic tourniquet. The benefit is completely obvious. It gives the surgeon a beautifully clean, bloodless field to work in. But for us, it introduces a whole host of physiological problems. Tourniquet pain is a fascinating thing. It's this deep, aching pain that's mediated by slow C fibers, and it often breaks through an otherwise perfect regional block after about 45 to 60 minutes. But the most dramatic event by far is deflation. The moment that cuff goes down, a whole wave of cold, acidotic, hyperkalemic blood from the ischemic limb just washes into the central circulation. And this causes a sudden drop in blood pressure, CVP and core body temperature, and a corresponding spike in end-tidal CO2, serum lactate, and potassium. It's a predictable storm every single time, and we have to be ready for it.
Right, so now we move to the next two horsemen, which are less about the surgical technique itself and more about the body's systemic response to major orthopedic trauma and surgery. We're talking about the critical and often fatal risks of fat embolism syndrome and venous thromboembolism.
This chart immediately puts the stakes into perspective, doesn't it? Fat embolism syndrome, or FES, isn't just some theoretical risk. It carries a mortality rate of around 15%. And just look at the incidence of deep vein thrombosis, DVT. After major hip or knee surgery, without any prophylaxis, it's an astonishing 60%. I mean, that's just staggering. These aren't minor complications. They are major threats to our patients' lives, which is why our management is so incredibly critical.
So the absolutely crucial point here is being able to recognize FES when it happens in the operating theater. While the classic triad of dyspnea, confusion, and a petechial rash is what we all learn in medical school, those signs often appear postoperatively. Intraoperatively, we are the first line of detection. A sudden, unexplained drop in your end-tidal CO2, accompanied by falling oxygen saturations, is a massive red flag. If you happen to have a pulmonary artery catheter in, you'll see a sharp rise in PA pressures. Now, the treatment is purely supportive. There's no magic bullet for this. It's all about aggressive cardiorespiratory support. And it's really important to note that despite what you might have heard historically, there's no good evidence to support the use of corticosteroids.
And that brings us to thromboprophylaxis, and honestly, one of the most important safety tables in our entire practice. These are the American Society of Regional Anesthesia, or ASRA, guidelines for performing neuroaxial anesthesia in patients who are anticoagulated. The absolute nightmare scenario we're trying to prevent is a spinal or epidural hematoma, which can be utterly catastrophic. I just want to draw your attention specifically to low molecular weight heparin, LMWH, because it's so commonly used. For once-daily prophylactic dosing, we must wait 10 to 12 hours after the last dose before placing or removing a catheter. For twice-daily dosing, that interval extends to a full 24 hours. Adhering to these timings isn't optional. It is an absolute standard of care.
Okay, so we've covered the major procedure-related risks. Now let's shift our focus to the patients themselves. Orthopedic patients often come with some pretty significant comorbidities, particularly the inflammatory arthritis, which require us to fundamentally rethink our anesthetic plan, especially our approach to the airway. We also have to consider the unique challenges posed by elderly patients with cognitive dysfunction and pediatric patients with conditions like cerebral palsy or osteogenesis imperfecta.
And this just brilliantly illustrates why. On the left, you have a normal lateral C-spine X-ray. Notice the lovely, clean alignment of the vertebral bodies. Now have a look at the image on the right. This is from a patient with severe rheumatoid arthritis. You can see that dramatic C1-C2 subluxation or atlantoaxial instability. If you were to perform a standard laryngoscopy on this patient, extending their neck, you could actually transect their spinal cord. This isn't just a difficult airway, this is a lethally dangerous airway.
So, how do we manage this? Well, for patients with severe RA, particularly those on steroids or methotrexate, preoperative flexion extension C-spine films are mandatory. In the theater, we must assume instability is present and perform intubation with manual inline stabilization, avoiding any neck extension whatsoever. This is where videolaryngoscopy or fiber optic intubation become absolutely essential tools. Now, for patients with ankylosing spondylitis, the problem is different, but no less severe. Their spine can be fused into a single rigid column, a bamboo spine, making any neck movement impossible and increasing the risk of fracture. In these cases, an awake fiber optic intubation is often the safest and really the only viable option.
Right, let's move into the application phase. We'll start with one of the absolute bread and butter operations of orthopedics, the total hip arthroplasty, or THA. Here, we'll see how all the principles we've just discussed really come together in practice. One of the biggest debates in anesthesia for THA is regional versus general. This table sums up the evidence beautifully. When you actually look at the major outcomes, neuroaxial anesthesia, so a spinal or an epidural, has some really significant advantages. It's associated with a lower incidence of DVT and pulmonary embolism, reduced intraoperative blood loss, far superior postoperative pain control, and potentially a lower risk of postoperative delirium, which is a massive issue in our elderly patient population. And that gradual, controlled sympathectomy you get from a spinal is often much better tolerated than the rapid hemodynamic swings of a general anesthetic induction.
Let's talk specifics for a moment. Positioning is key. Most THAs are done in the lateral decubitus position. This immediately creates a ventilation-perfusion mismatch as the dependent lung is compressed, but it's still being well perfused. Blood loss can be substantial, particularly in revision cases, so large-bore IV access is completely non-negotiable. Now, for bilateral procedures, a really critical decision point comes up. If the patient becomes significantly hemodynamically unstable after the first hip is done, the safest course of action is simply to stop and postpone the second side. The risk is just too high to press on. And for hip fractures in the frail elderly, the choice between GA and regional may honestly be less important than just ensuring timely surgery and robust geriatric co-management.
All right, let's move on from the hip and discuss two other major joints, the knee and the shoulder. Each one presents its own unique set of challenges, particularly when it comes to postoperative pain management and patient positioning.
The absolutely crucial point for a total knee arthroplasty, or TKA, is pain. These procedures are notoriously more painful than hip replacements. Because of that, our primary goal is to facilitate early and aggressive physical therapy, which is completely impossible without excellent pain control. This requires a true multimodal approach. Neuroaxial anesthesia is a fantastic foundation. This is then supplemented with peripheral nerve blocks like a femoral or an adductor canal block to target the specific nerves that supply the knee. The surgeon can also inject a cocktail of local anesthetics and adjunctives like opioids, clonidine, or ketorolac directly into the joint. And of course, all of this is built on a base of regular systemic non-opioid analgesics. It's this combination that really gets patients up and moving.
Now for the shoulder. Many shoulder surgeries are performed in the beach chair position, which you can see here. And this position introduces a very specific and very dangerous risk, cerebral hypoperfusion. Because of gravity, the blood pressure at the level of the brain will be significantly lower than the pressure you're measuring with a cuff on the arm. For every centimeter of height difference, the mean arterial pressure drops by about 0.77 mmHg. This is why it is absolutely critical to place the arterial line transducer at the level of the brain. We typically use the external auditory meatus as a landmark to get an accurate reading of the cerebral perfusion pressure. Failing to do this can lead to catastrophic outcomes like stroke or blindness. It's a simple thing to get right and a disastrous thing to get wrong.
Pain management for shoulder surgery is really dominated by one technique, the interscalene brachial plexus block. It is the absolute gold standard, providing dense anesthesia and profound postoperative analgesia. However, it's not without a significant side effect, phrenic nerve palsy. The block inevitably spreads to the phrenic nerve, paralyzing the ipsilateral hemidiaphragm. Now, while this is well tolerated by healthy patients, it can cause real respiratory distress in someone with severe COPD or other lung disease. For prolonged pain relief, a paraneural catheter can be inserted, and this block is very frequently combined with a general anesthetic for the procedure itself. And finally, let's address the pinnacle of orthopedic anesthetic complexity, major spine surgery. These are long procedures. They have massive blood loss potential, and they involve managing a patient in the most vulnerable position of all, prone.
Managing the prone position is all about a meticulous, systematic checklist. Before you even think about turning the patient, the airway has got to be bomb-proof. A reinforced endotracheal tube is essential. All your lines and monitors must be secured and checked. The turn itself is a team effort, a coordinated log roll. Immediately after you've turned, you must reconfirm breath sounds and tube position. Then comes the padding. Every single pressure point needs protection. Crucially, the abdomen must hang completely free of any pressure. This lowers intra-abdominal pressure, which in turn reduces pressure in the epidural veins and significantly decreases surgical bleeding. And finally, the eyes. You must ensure there is absolutely zero external pressure on the globes to prevent the devastating complication of postoperative vision loss from ischemic optic neuropathy.
So, we have covered a vast amount of ground today, from molecular physiology all the way to the practicalities of patient positioning. As we finish up, I want to leave you with this question to think about. We are in an era of enhanced recovery after surgery, or ERAS, and our regional anesthesia techniques are becoming more sophisticated every single year. So how does this change our job? Are we becoming more like perioperative physicians, managing the patient's entire journey, not just their time in the theater? How can we leverage these new tools to not just reduce immediate risks, but to fundamentally improve the long-term functional outcomes for our orthopedic patients? It's a really fascinating time to be in our specialty. Thank you for watching.